I have the pleasure, and we had a chance to get to know each other a little bit at dinner last night with these two great representatives. I'm going to ask them each to introduce themselves and what their interests are, and then we'll go through a series of conversational questions. So I'll start with you, Representative Riccelli.
Well, thank you, and thanks for inviting me here today. Obviously, for those who are outside of the community, welcome to the 3rd District. You're in it. It's what I represent. Please spend lots of money while you're here. We appreciate the economic engine of state of reform here these couple days. I came to the legislature after being elected in 2012. Have served on the healthcare committee my whole time in the legislature, but this year took up the role as chair after serving 6 years on our leadership team as the House Majority Whip. It's been a good transition. Some of my focus areas have been on oral health access, on telehealth, particularly food as health, food insecurity has been something that I've been passionate about and working with a lot of my colleagues. And the 3rd District, which you're in, is one of the most economically challenged areas in our state, and so making sure we're looking out for the most vulnerable is a priority for me. So I'm pleased to be here and look forward to having discussion and answering your questions.
Thank you. Representative Schmick?
Well, good morning, everybody. Welcome to Spokane. Isn't it beautiful out? We are glad to see it getting a handle on the fires, so you don't have the battle of the smoke, but it is an absolute gorgeous fall day, and we're so glad that you have joined us in Spokane. I represent the 9th Legislative District, which is 8 counties, and I'm sure that all of you already know where they're all at, but I'll just remind you. I have the southern half of Spokane County, Whitman, Adams, Asotin, Garfield, most of Franklin, Lincoln, and Columbia counties. About 10,000 square miles. So I was just telling Marcus earlier, I was very envious the fact that his district is so small, and mine's a little larger than that. I was appointed to the legislature in 2008. I have been the ranking member on healthcare in the House for 15 years. I think probably one of the more important issues for me, since representing a rural area, I have 8 critical access hospitals in my district, and that is rural healthcare and access to it, and making sure that there's survival of the critical access hospitals, because oftentimes those hospitals are one of the largest employers in those communities that they have them, and to make sure the folks there can get care that they need. I've worked with the former chair, Eileen Cody, for a lot of years, and now Representative Riccelli. We work well together. We don't always agree, but we can certainly discuss those issues. One of the things we talked about at dinner last night, Olympia is not the Washington as you read in Washington, D.C. We still have to get things done, and that forces us to talk about issues even though when they're uncomfortable, and then look for solutions. And I'm so glad you're here today. I'm looking forward to our conversation.
Yeah, that comment really resonates for me because I spent 25 years in Washington, D.C., so I'm really happy to be out here now, too. So so we're going to start with a little bit of a look backwards to this year, reflecting on what happened in the current legislature. What are you sort of thinking about as you've come out of that session and thinking about the next one? What are you looking at backwards, and what do you think maybe is left unfinished that you want to come back to in future ones?
Yeah, and it's always interesting to look into the crystal ball with the dance of legislation coming towards us, and with revenue forecasts and outlooks and all those things that bounce back and forth. But I think looking back is important because I'm proud of what we accomplished last session. Building upon a number of things, but we've passed measures to really increase access, reduce costs, and promote equitable care. You'll hear a lot more discussion in Olympia about health equity, and I think it's really come to the forefront, and rightfully so. We also, I think worth mentioning, we passed protections around reproductive access. I am very, very proud of our work on that, especially being somebody from a border community, and that includes protecting patients in Washington and providers. And I think that was an important measure. And then, of course, we made strategic investments across the board, but particularly in behavioral health. We know that our community won't thrive if we're not making these kinds of investments into treatment and care and making sure that people have the wraparound services they need. And that impacts our overall well-being of our community. So those are some of the, I think, key things that we worked on. I think we'll talk about a number of others. I mean, workforce. I'm in a room of people who are probably dealing with that by the minute, and those challenges. It's also, we're a citizen legislature. You don't get elected, and some sort of cap of knowledge is put on you. So it's slightly intimidating to come to a room with so many thought leaders. So I look forward to our discussion, and that's part of this conference is that, we need some of those policy interventions to come from the folks on the ground as well. So I look forward to some of the discussion. But looking backwards, I think we had a pretty significant session and continue to build on promoting affordable, quality care for folks and making sure it's accessible.
Great, thank you. What do you think about that in terms of looking back at what you've ended and where you're heading?
I think that I want to build a little bit on the rural healthcare part. We've got some significant challenges with the Blake decision that passed, which I did not support. I support it in concept, but we just don't have some of these services that the court will require in my rural counties. So it's something we've got to take a pretty significant look at. The 988 system that's coming up. Again, rural areas, we've got to have enough people out there that can do counseling. And so, I mean, why in these smaller communities we should be allowing ministers and the clergy to take the same training so that they can offer counseling to these folks in situations that frankly can be quite dire. And there's just not services available. Some of the other things that I think we need to continue to look at, EMTs. In the rural areas, it's a challenge. It's a challenge for the people to get the volunteers to come out. I'm not ignoring all of you. It's just they told me if I turn my head that way, the mic doesn't pick my voice up. But the EMTs and volunteerism, I'm really concerned about if someone would have a problem, and especially, let's look at the WSU kids as they travel Highway 26 right through the heart of my district. If there's a problem out there and they need an EMT, I want to make sure that somebody's showing up in those ambulances. And that is a challenge for our rural areas. So mental health counselors, substance abuse counselors, EMTs, volunteers in the communities. These are all things that really build into delivering that care for the folks in the rural area. I think one of the challenges that we find, or at least I find, and I try to help point out, is that one size does not fit all. What might work in an urban area probably will not work in a rural area. Therefore, there needs to be flexibility for those folks in rural areas to be able to deliver those services. And I will stop there.
No, but I think I actually want to take that a little bit further, because what you're describing is the rural issues specific within the state policy framework and the state programmatic framework. And so either one of you sort of take that theme next. How do you get the rural issues into the agenda and work on the tweaks that might be specific to this area? How are you approaching that topic? Are there things that you really want to push forward that need to be considered in that environment? And then I'll come back to you, Representative Joe.
Well, some of the things I've already laid out, and it's something that, and I'm going to refer to Representative Riccelli as Marcus, because we work pretty well together. Marcus is very receptive. We are trying to find pathways. We try to find things that are already working, and say, okay, can we spread that? What do we need to do to help that? Barriers. We've got to eliminate barriers into the workforce. Licensure. Washington does not play well with other states and with reciprocal back and forth, whether they've been trained and practicing in another state. Sometimes there's hurdles for those folks when they come to Washington. Anything that precludes people from practicing when they move here, we've got to lessen those barriers. And sometimes those barriers are higher hurdles for rural areas. Because, somebody lives out in Davenport, they don't have the Opera House, they don't have the theaters that you all have here in Spokane. It takes a special person to go out there who's willing to live in a rural area. And that's just reality. I've lived in a rural area my whole life, and I like it. But not everybody does. And so how do we encourage folks to want to be in a rural area so that care, which is so desperately needed, I guarantee those folks will be busy. But how do we do that? And Marcus has been good to work with as we seek solutions.
Thank you. What do you see this as?
Yeah, well, I mean, I'm certainly grateful and appreciative of all that Joe brings to the table and the perspective. But I'm also, there's self-interest, right? I represent the 3rd District. We're an urban center with rural areas around us. We know that we can't be successful if we don't have those communities thriving around us. That was very clear. A number of us worked on the policy to create a second medical school in the state, a public medical school in the state, with the idea that we need to have more people going to our underserved and rural areas, growing that with what UW is already doing. So there's a real recognition that those communities can't thrive if they don't have access to care. And so I think that that's really important. I think speaking of rural areas, from a public health standpoint, something that I've really been trying to be a student of over the last 3 or 4 years and try and engage in. I think we should treat public health in our rural areas the same way that we treat public safety. There should be a basic level of service no matter where you go and expectations on that. So I think we have a lot of challenges. I agree with the difficulties in recruiting folks. That's why I think we need to look at what we're doing on the other side when we graduate people. What are we doing with student loan debt to incentivize them to go into these areas? How can we work with those communities to provide loan repayment and other incentives? Because we know if they spend a few years in that community, that lifestyle could really take to them. Now, if it doesn't too, and they go and spend 3 and 4 years in one of these underserved communities, then that's great as well, I think.
That's great. Can I ask a little bit more about the rural hospital situation, which we've seen in this region, in this state? Let's take a little bit of a next step. Where do you see as being the possible responses to some of those issues? Where do you see that topic going? And then we'll get into some other questions.
Yeah, I mean, I'd like Joe to start because that's kind of, he has the lived experience in the community.
A lot of my smaller hospitals, frankly, and the reason why, and people ask, well, why do you need all those little hospitals? And so I challenge you to go home and do a little exercise. Put a pin in the state of Washington on a map and make it red so you can see where all those pins are. When you start removing those pins, start thinking about the access and the timing and how long it takes them to send somebody out and to bring them back in. And you're way past that 45 minutes to do that. So there are certain requirements to be classified as a critical access hospital, and it's one of the things I've talked with our congressional congregation. Is there a different model that could serve these communities? And what would that look like? And that's one of the things I'm exploring. I'm also, I don't want to say too much, but I'm working with one of the MCOs in one of my smaller critical access hospitals to try to identify certain procedures that the global payment could be made or a lump sum to take care of that person. And then if there's savings, that the MCO in that hospital would split those and share those savings. And that's something that we're working on a pilot right now to try to find. I'm looking for ways to make sure that our critical access hospitals are financially stable. They were doing fine during the COVID when there was some extra money flowing that way. But I've also had CEOs tell me of the smaller hospitals and now when that money runs out, we're in trouble. And I think that if you follow and watch and monitor the financial condition of a lot of hospitals, and frankly, it's not just critical access hospitals, it are all the hospitals. Their margins are thin. and they've got a challenge. And I think it's up to us to try to find ways that we can keep them financially stable and in the communities, frankly.
Very good, very good. I am going to get to audience questions in a few minutes, although I actually forgot my watch, so I have no idea how much time we have
It
left.
is 8:56.
Terrific, thank you. That cell phone's over there. I use it for everything. Thank you for that. So we have a few more minutes. I wanted to go back to the crystal ball that you mentioned. What do you see is on the agenda? Is it in the hospital arena? What do you see on the agenda for legislation next year?
Across the board, again, I think workforce issues, how we're reaching out. COVID really kind of shined a light on how we interact and how we deliver care to some of those harder to reach communities, and I think that's really important from a health equity standpoint. And then there's just, we've seen at the national level. I think our state's been a leader that there's these, housing is healthcare, food is healthcare. How are we embracing that as a state? How are we funding that? How is that intertwined with the waiver, and just what are we doing to, take care of the whole person? I think a big piece of that, once you can make sure people have stable housing and have food in their belly. I went to Gonzaga right over there, and that's where the Jesuits, really informed me about Maslow's hierarchy of needs, and there's no self-actualization if you can't get those basics taken care of. And so I think we're just desperate in our communities to make sure that people have supportive services so that they can, it doesn't make any sense for folks who are unhoused to go to our hospitals, get care they need, and then be sent back onto the streets so that they can just return to the hospital because they haven't had respite care, things like that. So I think diving into all the supportive services that are needed, and I think particularly around behavioral health, so mental health services, and that just gets back to workforce. And I would like to put a plug into, we're always looking at the shiny new penny. How do we get more people in? Let's just remember that 20% of professionals left the healthcare professions during the pandemic. So what are we doing to reduce burnout and retain the folks that are there? And that's, I'll mention it a little bit later, but thanks to people like Jeff Thomas, at least on the behavioral health side, we're able to increase pay for people. And that was a very meaningful conversation that I had directly with him, where he said he had people who had tendered their resignation, but when it came out that we were going to be funding at different levels, those folks decided to stick around. So what are those things that we can do? And sometimes it does just come down to money. That's a way that we show we value professions.
Good. What do you see on the agenda next year in terms of, or what would you like to see?
Well, there was a number of things we didn't get done. I have a list.
Oh, I love it.
Well, just because there's a number of things where there's a push for art therapy to be licensed. That's new. Nurse anesthetist assistants, that issue is still out there. Fertility services is still sitting out there. Biomarkers, that's out there. Whole genome mapping sequencing, another issue. And I'd like to open up another can of worms. I really wonder if the reasons why we have certificate of need are still prevalent. When I was speaking of barriers before, I'm wondering if that isn't a barrier for what we need. And the thing I'm going to speak is Joe. Joe thinks that you have 5 hospital systems in the state, and they seem to be much more interested in divvying up the areas rather than competing. So, that's reality. It's what the market has in front of us now. And what are we going to do? What can we do to introduce competition into the fields and whatnot? So if barriers are put in the way, I think we need to take a look at those. At one time, certificate of need has been around forever, for a long, long time, but I think it's time we take a look at it. Along with that, with other things, let's lower those barriers so that we can welcome the folks that want to come to Washington State to be able to practice.
I would just add, because we like to have uncomfortable conversations. We did that with Scope of Practice last year. We kicked that door open and people were like, what are you doing?
Well, I was going to leave that off.
Yeah, we leave that. But for me, kind of my issue that aligns with that as far as kind of shaking things up is I'd like to see a double down of effort around the focus on what's going on in other states around cost transparency and looking at patient affordability as we move forward. Skyrocketing costs, for the people I represent and for my role as chair, we have to continue to look at how we're making things more affordable, and we're not going the right direction, and there are outliers out there that we need to find correction towards.
Well, I'd like to throw in, we've got to talk about prescription drugs. You talk to every carrier, it is a huge cost driver. Do I know what the answer is? Nope. But we're going to have to continue to work on that and continue down that pathway. Sorry, I didn't mean to interrupt.
No, that's not interrupt, that's discussion, that's great. And I think, one of the things we talked about in planning for this conference was the impact of cost of care on attracting businesses to the local area. Creating a thriving economy can be slowed down when there's not a sense that you can do business in that area because your employer coverage is going to be too challenging. So it's not just a public program issue, it's really this affordability issue across programs is a challenge. And it's one that you have to tackle, to your point. We don't know all the solutions, but we gotta be transparent and we gotta be conversational about it, I think is right.
And I think that being on the border, as we both represent areas, we see the migration of people leaving the state. I got Pullman, Moscow. I have Lewis and Clarkston, and a lot of businesses that just are jumping. Example, Schweitzer Engineering just built a huge manufacturing plant in Moscow, bought 300 acres. So, and Dr. Schweitzer has told us all along, he said it's too hard to do business in the state of Washington, and he's talked about it for years. Well, they moved, and that's where their expansion is going to be and everything that they're doing. So we have to be cognizant of those things to keep our people here, to keep providers here. It's all tied together. But we've got some unique challenges when you're on a border part of the state.
It is fascinating. I mean, my only little pushback on that is when you talk to some of these companies that either move or talk about moving and you ask where the CEOs live, a lot of them live in Washington State because they want their kids to be educated here. And so, there is that push and pull of investments. What are we doing? And making sure we're looking at that environment across the board. Idaho just went to 4-day school days because, they can't, that's one of the things they're doing to recruit and retain educators. And so it's such a balance across the board, and it provides difficult challenges being border community. And that's one of the things I think Joe and I, sometimes we might not have the same perspective, but we bring kind of that Eastern Washington perspective that I think helps inform our whole state and our caucuses, quite frankly.
Mm-hmm. That's great. Before we turn it over for audience questions, anything we didn't mention that you wanted to make sure you threw out there? Any other issue on your burning list?
Lots of conversations around Medicaid redetermination. I think that's important. Lots of conversations around us bringing on coverage for folks who haven't had access traditionally to coverage. I think these are important topics. How we implement those will probably be, in addition to some investments and other things, will be up for some additional discussion. And then for me, it's just continuing to bring those things that maybe haven't traditionally been seen to our colleagues. You all get, but I know we're supposed to call it something else, but social determinants of health, housing, and food. And so I'm excited to be trying to continue to close the door on universal meals for kids, because I think child nutrition is extremely important in addressing hunger, and I think we're getting close. We've passed 3 bills in Washington State that I've authored. We got 2/3 of our kids covered. So I like to say that in front of a healthcare group to just make sure there's support out there for addressing hunger as a healthcare issue. And I think if we frame things in this hyper-polarized way, that hyper-partisan environment we're in, if we can, when we look at we didn't even talk about gun violence and things like that, but if we can talk about them as public health issues and health issues, then maybe we can get back to the conversations on the merits of the policy interventions brought forward.
Great, thank you.
There's one more rural thing that I think I like like all of you to think about. I live in Colfax. I drove up this morning to get here. Think about all those folks that live in rural areas that when they do have to come to Spokane to get the health care services that they need. That means they most likely had to take time off. They had to find somebody to take care of their kids. They traveled up here. They sat in the doctor's office. They travel home. That often takes a full day that they're doing. So travel and time of the patient, let's not lose sight of that. And how do we deliver these services? Both Marcus and I sit on the telehealth collaborative, and although I don't think it's probably the silver bullet, there are opportunities there that we need to take advantage and to make sure that we're delivering care. If it's too hard to come to the doctor up here, people won't go. And how does that help with overall health of that person? It hurts. And so I wanted to bring that up because I think that that's something, if you live in an urban area, you don't think about. But boy, people in my area do. And it's a challenge. And boy, when the roads get bad in the wintertime, it makes it that much harder. Then you might have to come up and stay overnight, which helps the 3rd District's economy, but it makes it that much harder for those folks to get the care that they need and probably more apt to skip that care.
Well said. We're the technology state, and we heard a lot of discussion around education and jobs during the pandemic and digital equity, but healthcare was kind of outside there, and so digital equity for access to healthcare is critical, and I think particularly in our rural areas. But also I remind people, right here in the 3rd District in an urban center, there's a lot of people that can't afford to be connected, and we need to work on that across the board. And I think we're doing pretty good. We're making huge investments, but just making sure that healthcare is a key component of digital equity.
I think that's great. So Representative Schmick, how much time do we have left?
It is 9:08. So
okay, well,
you've
that's
got
how much time you all
questions.
have, so somebody's keeping track. Are there any questions from the audience in terms of things you want to put out there?
And you're going to set up appointments with all of us in our offices in Olympia, so now's the time. Do it in front of everybody. Ask
You're
us
right
some
here.
questions. There we go.
Got one right here. Got a mic coming to you in a second.
Good morning. I'm Christina Clem with AARP Washington State Office. Thanks to both of you for the work that you've done to help the older adults in the state get the care that they need. One thing that we're considering in the next legislative session is the idea of billing for ground ambulances. The surprise billing issue, I think we've tackled pretty well with people, the anesthesiologist that worked on you maybe not be under network. But there's still some outlying issues with ground ambulances and surprise billing. So wondering if either of you have any opinions, ideas on that.
Go ahead.
There's a report that's been done by OIC that's in draft form, and actually next week I get briefed on that. I've not seen the draft, but it was an issue when we had the balanced billing that was left out. The air ambulances were covered, but not ground, and so we'll look to that report to kind of see what items they've identified that we need to work with, but pretty important topic, especially in the rural areas. It is also. So I'm not deferring. I just would like to see what OIC has come up with the research that they've done, because I know that they've been talking with the congressional in Washington, D.C., the congressional folks about it also. And so allow me to kick the can on that one.
I'll kick the can too to a table right over there where OIC is represented. And, I think it's an important issue, and it merits discussion, and I think we look forward to getting better educated.
Great. Oh, we have one over here.
Hi, I'm George Wilson with Greater Inland Northwest Advisors, and I've been doing a lot of work over the last year with community paramedicine, mostly in rural areas, looking at urban areas too. Basically, it's EMS doing home visits and looking at patients, not only their health needs, but housing, nutrition, transportation, that sort of thing. You get really great improvements in patient health, but for the most part, EMS can't make it work because the vast majority of the visits that they do, they can't bill for because they're not transporting people to the hospital. There are some other ways to maybe financially make that work, but it's been really difficult. I'm just curious if there's any discussion in the legislature about opening up some of those reimbursement pathways.
I think that everything's on the table. We have an aging population in the state, and we need to be looking for ways, all kinds of ways, to be able to deliver care in a position where the people are going to do the best. And they will do their best if they stay at home, familiar surroundings, without them losing their home and having to go to another facility. I'd like to hear more about what you're doing, where the shortfalls are, and take a look at it, because I think everything's on the table.
Sounds like an interesting issue. I think one of the things that I was just talking about yesterday was about hospitals and looking at capacity, and are there scenarios where yes, people probably should be admitted to a hospital, but with capacity issues, they could also potentially get some care at home. And so I think that that's an interesting topic of discussion, and look forward to that, and would love to hear more about the work you're doing and some of the barriers to providing more access at home when it makes sense.
I heard just yesterday that one of the hospitals has a program that they're working on to try to deliver care in the home for those things that don't need to go to the hospital. So there are things going on and things happening, and if we can do better and make it broader and across bigger areas, I'd sure love to talk about it.
And I do understand there's some movement as well in Medicare on those topics, in paramedicine and in home-based care and home monitoring, and even hospital at home, which is some of the things we've been hearing about. So certainly something to keep an eye on at the federal level too. Any other questions or points? Oh, yeah, one more. And we have time, right? So we got one more.
You're doing good.
Good, thank you.
I'm Jack Davies. I'm with the Rural Collaborative, which is a coalition of 24 rural hospitals across the state, including several in Representative Schmick's district. I just want to echo what you were saying about certificate of need, the need for flexibility, particularly in issues like home health and hospice care. In many situations, those agencies that have the certificate are based in an urban center, and say they will send staff out to provide support to residents in rural communities, and that care is very hard to, in fact, to receive. So we need different models for that type of care, long-term care, as we have aging populations in rural communities.
Yeah, thanks. And looking ahead, and this is part of how Representative Schmick and I work well together. I knew this is an issue that he's been interested in. So for a work session in October, we're going to be looking at the certificate of need process and kind of getting a level set, making sure committee members at the very least are up to speed with just what it is, et cetera. And I think that will help launch some discussions. And I think I'm appreciative that Representative Schmick's bringing that up and that we can explore that.
And I would like to challenge all of you, if you have ideas about different ways that we can deliver care to take care of the population, please do not hesitate to talk to us, talk to others, but boy, let us know what you're thinking. There's something that we can build and do. Absolutely we'll want to do it. We have to be innovative, and because we're not going to be able to do stuff unless we're not innovative. So let's figure it out, and you can all help. So.
Except for Senator Frock, former Senator Frock. He had his time. Big shout out to a big leader in our state I wanted to recognize. Thanks for all your work in the legislature, Senator Frock. It's great to have you in Spokane.
Thank you. Well, these and other topics are going to be on our agenda for the remainder of the day. What a great start. What a great opportunity. Really appreciate your time. Please join me in thanking you, Representative.